The GFR measures how well the glomeruli filter blood plasma through renal corpuscles. Clinically, this is the foundation of kidney function assessment. A decreased GFR means filtration is impaired. This could be due to, and often is due to, glomerular or tubular damage. The GFR typically is estimated using serum creatinine because it's a small molecule that's freely filtered. However, true measurement of GFR requires substances like inulin or radioisotopes, which are rarely used in a routine practice or a routine screen. So, as I mentioned, ideally or theoretically, the ideal substance to measure GFR should be freely filtered at the glomerulus, not protein bound, not metabolized, not secreted or reabsorbed by the tubules, and it should be stable and easy to measure. It should also, in research, we kind of jump to inulin as being the ideal standard, as it fits all of these criteria best, but it's really not practical when it comes to measuring this from a clinical perspective. That's why creatinine is used as a surrogate instead of inulin, because it's produced at a relatively constant rate from muscle metabolism. It's excreted mainly by the kidneys, although it slightly overestimates GFR because of tubular secretion. When we look then at the BUN to creatinine ratio, it's one of the simplest ways to differentiate between pre-renal and intrinsic renal causes of azotemia, which is an elevation in nitrogenous waste products. And this is kind of showing you some causes or categories of pre-renal, intrarenal, or post-renal causes of acute renal failure, kind of what we might be looking for in these patients. So let's say we have a high ratio, which is greater than 20 to 1, like we see over on this left side. That suggests a pre-renal cause, like dehydration, shock, or heart failure, because urea reabsorption increases with slower flow. A normal or low ratio, around 10 to 20 compared to 1, points towards an intrinsic or inside the kidney cause, things like renal disease, acute tubular necrosis, glomerular damage. And this ratio can give us a quick functional snapshot. And so we can look at the BUN and the creatinine that we get in a CMP, and we can kind of assess, is there any damage happening to our kidneys? Looking here, you can kind of see some tests, the pre-renal versus intrinsic in acute renal failure. So when differentiating between pre-renal from intrinsic acute renal failure, lab patterns do become really helpful. And so in pre-renal azotemia, reduced blood flow to the kidneys, such as from dehydration or heart failure, causes a disappropriate rise in urea compared to creatinine. So that ratio. Protein is rarely seen in the urine in these kind of phases because the renal parenchyma itself is intact. But in intrinsic or renal azotemia, like acute tubular necrosis, for instance, both urea and creatinine rise together, and protein often appears on urinalysis. So when you see protein on a dipstick, think about intrinsic or tubular or glomerular injury. So looking back on this slide, it further kind of clarifies how we can see in these pre-renal phases a sudden drop or severe drop in blood pressure or shock can interrupt blood flow to the kidneys that can cause severe injury or illness. In intrarenal damage or intrinsic damage, direct damage to the kidneys itself. This could be inflammatory, toxic, drugs, infection, or from reduced blood supply. And then post-renal, this is our obstruction and flow. So kidney stones, a prostate issue, bladder issues, bladder tumor, injury, anything in this kind of three phase is blocking urine from escaping the kidney. So to kind of pull these pieces together, the estimated GFR is often what we'll see on a CMP or reported in conjunction with a CMP, and we'll see it as small e GFR. It's very commonly seen on modern chem panels, and it's calculated using equations. There's several different equations, the MDRD or the CKD epi formulas. These include serum creatinine, age, and sex. Some calculators also do adjust for race, although that is being phased out as we found that it doesn't provide clinical accuracy and can, in fact, decrease diagnosis, early diagnosis in certain different racial minority groups. And so we found it to be one of those other examples of potential or actual racism in medicine. So you'll see some EGFR calculators that have a race nomener in there, and we are now seeing those being phased out as they were on data that wasn't valid. The key idea with any of these calculators or calculations is that as GFR decreases, serum creatinine increases. eGFR helps us to track kidney function over time and detect chronic kidney disease early, which is a goal for management because we want to try to maintain healthy kidney function. This also can help with medication dosing determinations. It's automatically reported anytime we see a serum creatinine. That being said, you sometimes do need to check your chem panels because sometimes you'll have a CMP and then a CMP with eGFR. You always, if you're really concerned about kidney function, you always want to make sure that there's a GFR present. There are some limitations to eGFR, estimated glomerular filtration rate. Um, it's very useful, but it's not perfect. The equations assume average muscle mass for an individual, average dietary intake. So they could be inaccurate in certain clinical populations if someone was a vegetarian or vegan, someone who's pregnant, someone who's really young or really old, or someone who has muscle disease or even malnutrition states. When eGFR is also above 60 milliliters per minute per 1.73 square meters, the equation tends to be less precise. And so that's why right now, a lot of times you'll see a normal GFR is just anything above that 60 milliliter per minute moniker. In these cases, when we do see numbers above that value, if exact kidney function was needed for things like chemotherapy dosing, we would actually use a measured creatinine clearance instead. When we come back, we will look at what creatinine clearance is and then talk about how we start to collect 24-hour urine samples.